there's some people here today who were not here yesterday, so I'll reintroduce you, Dr. Carroll. So Dr. Ian Carroll is pain management. He's on faculty at Stanford, correct, and anesthesia. And he started noticing that some headache patients were being misdiagnosed as chronic migraine. But it was a real esoteric bag of symptomatology, kind of like IIH. Well, they've got this, but they don't have that. She's fatigued at the end of the day, but who isn't with 3 kids, So he started collecting all these journal articles from anything that's been written about CSF and CSF leaks and high pressure and low pressure and how pressure is measured and all that stuff. And he basically became one of the top 3 experts in the country, or one of the only 3 people doing anything in this field. And it's spontaneous CSF leaks. And we're not talking about CSF leaks where somebody just had an epidural yesterday and then they have to go and get a blood patch. We're talking about spontaneous leaks, like you may never know what caused it or how it got caused, or it might not have a cause, but you might be leaking CSF fluid for 25 years and everybody's called you a malinger or a chronic migraine patient and nothing's ever worked. And then once we figure out the real diagnosis, that's why diagnosis is key, then we can get you, some of those people, we can get them fixed pretty easily. So some of them can get fixed with just one blood patch. But if you're not looking for that needle in the haystack, I can tell you, you're never going to find it. So we went back to our people, we pulled all the charts, the people who have a chronic daily headache, who never get down to pain zero, and we re-asked all the questions. Were you very limber when you were 5? So here he is.
Thank you all for coming back. I'm going to talk a little more about spinal fluid leaks. We talked about them yesterday. And I just want to say how nice it is to be back in Mississippi. People have been so friendly here. It's been a very nice experience. Anyhow, let's get into it. The first, I have no conflicts of interest. I don't work with any companies. The work that you're going to hear about is supported in large part by the Considine CSF Leaks Fund at Stanford. I want to say thank you to that family. Indispensable help came from a number of people. We mentioned them yesterday. Rob Cowan, the Stanford headache faculty, Stanford Neuroradiology, and the Neurosurgery Department. It's been a team effort at Stanford, and I'm glad to be able to talk about what we've accomplished as a team. So the first question is just how rare are spinal fluid leaks? And I want to tell you the best work in this field has been done by Wouter Schivink and his team at Cedars-Sinai. They did something interesting no one else has done. They went and looked back at the MRIs that were that they got in their emergency department over a 3-year period from patients who came in complaining of headaches that were bad enough that they prompted an MRI. And what they did is they counted the number of MRIs that actually had evidence of intracranial hypotension, and they counted the number of MRIs that showed evidence of aneurysmal subarachnoid hemorrhage. And in that 3-year period, they counted up essentially 20 cases of aneurysmal subarachnoid hemorrhage and 10 or 11 cases of spinal CSF leak. Okay? What was interesting is the incidence of aneurysmal subarachnoid hemorrhage is known. It's about 10 per 100,000. And since they had essentially 2 cases of subarachnoid hemorrhage for every 1 case of CSF leak, they're able to estimate that the incidence of CSF leak is about 5 per 100,000. So I think there's 2 things to reflect on there. Number one is nobody thinks of subarachnoid hemorrhage as particularly rare. And for every 2 cases of subarachnoid hemorrhage, we should be diagnosing 1 case of CSF leak. And we're clearly not. The other thing that was interesting about this is when they went back and looked at how many of these people who had MRI evidence of CSF leak on their brain MRIs, how many of them were appropriately diagnosed when they came to the ER? Of the 11 cases, 0 were appropriately diagnosed. So it is not that CSF leaks are rare, it is that the appropriate diagnosis of CSF leaks are rare. Now, I find it hard to understand what an incidence of 5 per 100,000 really means. So let me put that in perspective for you. The incidence of suicide in the country is 13 per 100,000. The incidence of esophageal cancer is 4 per 100,000. This makes CSF leak more common than pancreatic cancer, more common than bladder cancer, more common than uterine cancer. And it makes it something that frankly should be seen in a major medical center every day. The known risk factors are having a hereditary disorder of connective tissue. Right now, the prototypical hereditary disorder of connective tissue is Marfan syndrome. But we also know that there are others. There's Ehlers-Danlos syndrome. Neurofibromatosis type 1 is known to have a connective tissue phenotype. And in fact, what you find is even people with joint hypermobility without any specific genetic diagnosis are much more likely to be found in patients with CSF leak. So how do you know when your patient's connective tissue isn't right? With Marfan, the reason that they're tall is something about the FBN1 mutation that causes Marfan causes the long bones to fuse the growth plates later. And so those bones wind up longer. And the same failure to fuse the growth plate is what winds up creating a pectus excavatum in people, or a pectus carinum, where the chest is kind of bent in. You will see that in patients who have abnormal connective tissue, you'll often get things like early cataracts. We talked about hyperflexibility. If you can do this with your body, your connective tissue is not normal. This was a patient who came in to see me in the clinic. He was complaining of headache. This was not me doing a physical exam. This was a nervous tic that he happened to have. So he walks in, he has no idea that he has a leak. He's not suspecting a leak. He's not seeing me because I'm a specialist in leaks. He just happened to walk into the pain clinic wanting help with his head pain. And he's sitting in front of me, interested in leaks, doing this with his finger as a nervous tic. That's like screaming, please look for a leak, right? Like, you know. This was one of the very first patients we saw. When I started being interested in leaks and seeing how people were getting misdiagnosed, I reached out to the clinics at Stanford where I had seen that previous patients had been seen but misdiagnosed. And one of those clinics was the POTS clinic. It turns out at Stanford there's 2 separate POTS clinics. Because if in fact you're a young woman and you feel worse when you're upright, you feel better when you're flat, unless you're very clear that the dominant symptom is headache, when you go in saying, I feel all kinds of neurologic symptoms when I'm upright and I feel better when I'm flat, odds are you're going to get diagnosed with POTS, postural orthostatic tachycardia syndrome. So one of the things that we did at Stanford that was a little different was starting to reach out to these other clinics and making them more aware of CSF leaks, and to be aware if they saw someone with POTS who was hyperflexible, who complained of headache as a big part of their syndrome, just send them to us. We'll work them up and we'll see. This was one of the first ones. And in fact, you can see she's bent back her thumb to touch her forearm while crossing all of the fingers over another. That's kind of a neat little trick. Right now, most of what we know about hereditary disorders of connective tissue comes from the literature on aortic aneurysms. All right? Aortic aneurysms have now been associated with all of these different connective tissue things. All right? So the list keeps growing. It's not just Marfan's and Ehlers-Danlos anymore. We know more and more about connective tissue diseases that wind up with distinct phenotypes. And let me tell you, if your connective tissue isn't strong enough to keep your arterial pressure in line, it's probably not going to be strong enough at some point to bear you through the processes and stresses that we apply to our dura. What about iatrogenic leaks? This is one of my favorite papers. Pam Flood is an anesthesiologist now at Stanford, was at Columbia when she did the work in this study. So what she did is she did a case control study looking at 40 cases at Columbia Presbyterian in New York who had accidental dural punctures when they were getting their labor epidural. So the known consistent rate of having an accidental dural puncture when doing an epidural is about 1 to 2%. And so at Stanford Hospital, we're doing, I don't know, something like 20 to 30 epidurals on labor and delivery every single day. So you play that out, that's maybe 150 epidurals at Stanford Hospital a week. And so we're probably creating 1 to 2 dural punctures a week in that one hospital. So what happens to those patients? She looked and matched those 40 cases of accidental dural punctures with 40 controls. Who were the controls? They were women who had epidurals the same day for labor and delivery, but didn't have an accidental dural puncture. And what she did is, which is really unique, is she looked at them not the next day to see if they had a post-dural puncture headache. These were all known accidental dural punctures. She called them a year to 2 years later and asked them about whether they had new chronic headaches that they did not have before their dural puncture. And in fact, what you see is if you had an accidental dural puncture, 28% of those patients reported new chronic headaches that had started with their childbirth. And in the control group, because otherwise you might think maybe this is just because you have kids and now you're sleep deprived, et cetera, et cetera. In the control group that didn't have that dural puncture, only 5% report new chronic headaches. All right, so nearly an odds ratio of 6. That's a huge effect. All right, now, what you should understand is these were recognized dural punctures. Everyone had thought these patients had been treated appropriately. It's not like they had dural punctures that weren't recognized. If they got a blood patch, which is 25 of the 40, their rate of having new chronic headaches is less than 28%. It's 20%, okay? If they were managed conservatively because somebody thought, oh, their headache's getting better, they're not complaining of any terrible headache 2 days later. If they were managed conservatively, if you have a dural puncture and you don't give them a blood patch, the rate of having a new chronic problem is 40%, all right? That's almost half. So the other thing that I would point out is the efficacy of a single blood patch in preventing long-term problems. You've all been taught that if you have a post-dural puncture headache, that getting a blood patch is 80 or 90% effective. But in terms of preventing chronic problems, it cut the rate in half. I will say, before I move on, the other thing that they found in this research is if you had an unintended dural puncture, the other thing that was much, much more common in the people who had the dural puncture compared to people who had epidurals but no dural puncture is back pain. These patients had a much higher incidence of chronic back pain, all right? Suggesting that spinal fluid leaking out, in fact, is irritating to the tissues around it. This is a problem in part because everyone with a spinal fluid leak, whether it's in your tailbone or in your lumbar spine, has neck pain. And so every patient that sees me with a suspected leak, their neck is killing them. And they're saying to me, can you patch me up here? I'm pretty sure the leak's right here because it's killing me right here. But usually, in fact, the leak is not in the neck. So just so that you know that Pam Flood's paper is not the only one, this has now been reproduced in a much larger sample, looking at, in this case, 308 unintended dural punctures in 50 controls who had epidurals without a dural puncture. And interestingly, the incidence of new chronic headache, this is now 6 weeks out, not 2 years out, but 6 weeks out is pretty good. The incidence of new chronic headache is actually the exact same thing that Pam Flood found, about 1 in 3, compared to only 2% in the controls. And like Pam Flood's paper, the incidence of back pain also way, way higher in the patients who had unintended dural punctures. So this is the MRI from Caitlin, a young woman who at age 20 had surgery at Stanford for a labral tear. Why does she need surgery at age 20 for a labral tear? Maybe there's something a little funny about her connective tissue. Who knows? In any case, she woke up in the recovery room and was screaming in pain. She was seen by the acute pain service at Stanford that appropriately offered her an epidural. Because she now had her surgery, she couldn't sit up to have the epidural, as is the normal practice for the vast majority of epidurals. But a good anesthesiologist can often slip one in with somebody in the lateral decubitus position, so they rolled her on her side. But because the positioning is a little different than typical, probably that contributed to the fact that the resident placing her epidural accidentally gave her a dural puncture. All right. Resident told her, I'm sorry, we got into the spinal fluid. I can't put this catheter in there. Do you want me to try again at a different level? She said, no, I've had enough. Stop poking me. They started giving her fentanyl and Dilaudid to try to get her pain under control. She didn't have an actual epidural catheter placed after the unintended dural puncture. She was seen by the pain service the next day at the hospital, was told about dural punctures and how they could cause spinal headaches and was offered an epidural blood patch, and she declined, remembering how uncomfortable it was to have that needle in her back the day before. And they said, no problem, if your headaches, if you start having headaches and they're a problem, let us know, we're happy to come back and blood patch you. She was more preoccupied at that time by the pain in her hip, and of course she's in the hospital. She's not walking around because she just had hip surgery, so how is she in fact positioned? She's lying down, you got it. So she is totally preoccupied with her hip. She is half drugged on opioids, and she's not upright anyhow, and she very quickly forgets that there's anything called a spinal headache or that she had an unintended dural puncture. And she goes home to recover from her hip, and she wanders into the pain clinic 18 months later, having dropped out of school because of these terrible orthostatic headaches that she has been having. One of my colleagues saw her in the pain clinic and did, I think, something quite remarkable in terms of trying to go back and look in her medical record around the time when the headache started, and noted and found in the record. She didn't offer up. He found in the record, this all started around your hip surgery and you had a known dural puncture. And so we very quickly identified her as possibly having a leak. Here's her brain MRI, read as totally normal at Stanford. All right. You'll remember from yesterday that, in fact, having a convex up pituitary is more common in people with leaks, although it's not diagnostic. You'll remember that having a little narrowing of the suprasellar distance, less than 4 millimeters, is predictive of having a positive CT myelogram. Anyhow, the point is, she doesn't have any clear brain sag, and she had no pachymeningeal enhancement, and it was read by good neuroradiologists as not showing a leak. And this is my daughter, the person who got me interested in this in the first place, because as part of medical workup for her, she had a number of lumbar punctures and wound up with a chronic CSF leak. And it took us a long time to figure out that was what was going on. And things were very rough for a while. And when we treated her, and when she got treated finally for her leak, is when things got much better in our lives, and I started reading more and more about spinal fluid leaks. And as I was reading about them, wondering, where they were in the medical center, why we weren't seeing as many as the literature said we should. So spine surgery, also a known precipitant of CSF leaks, multiple papers about this. You can imagine if you're putting pedicle screws down these pedicles, or you're doing laminectomies, it's really easy to accidentally tear the dura. One of these pedicle screws is 2 millimeters too medial, and you're in the dura. And you know what? You know how easy it is to find a spinal fluid leak here with all this metal creating artifact on MRI or CT? It's basically impossible, all right? And what happens after you get spine surgery? Are you up and at it right away? No, you're also laying flat, right? And so you become aware of it later when you start weaning off of the opioids that you were taking for your back pain, and then you start suffering more, and you go back, maybe you say something to your spine surgeon, or maybe you don't. Maybe you assume the new headaches you're having are because of the drugs you're taking or something else, right? Aren't these cases easily recognized on neuroimaging? Or asked another way, how sensitive is imaging? So this is a research article that came out a couple of years ago. This is maybe the largest series that anybody has ever reported on looking at imaging for CSF leaks. It comes out of Japan. And they were looking at patients and the correlation between radionuclide cisternogram and MRI. So they looked at 250 patients who they suspected had CSF leaks. And their suspicion was strong enough, based on orthostatic headaches and other associated symptoms, that they were willing to go forward with an invasive and radioactive test, a radionuclide cisternogram, which they use preferentially in Japan. And so of these 250 patients with orthostatic headaches, they found 186 had evidence of CSF leak on radionuclide cisternogram. The vast majority of them also had MRIs. 21, only 13% had any brain sag at all on MRI. Exactly one patient out of 186 had pachymeningeal enhancement, suggesting that the sensitivity of MRI for a CSF leak is terrible. All right? Now, Rigmore. If in fact, so 21 patients have brain sag on MRI. Only one of those 21 has pachymeningeal enhancement. I can tell you at my hospital, if you have brain sag and no pachymeningeal enhancement, what you get diagnosed as. What would you get diagnosed as at your hospital? If you had headaches, you had evidence that maybe your cerebellar tonsils are coming out the foramen magnum and it looks like brain sag, but there's no pachymeningeal enhancement at all. What's the top diagnosis on that MRI report? Yeah, Chiari. Raising the question, how many people, go ahead.
Every so often, and we are really in trouble afterwards.
Yeah, that's right. How many people with Chiari are coming from this group, right? Scary. How many people who are getting operated on for Chiari have an MRI with contrast to potentially find pachymeningeal enhancements before their surgery? How many are having full spinal imaging? And how good is the spinal imaging at reassuring you that it's not, in fact, a leak, right? How many of these patients are told to do something like that 48-hour flat test I talked about yesterday? Told to get flat for a prolonged period of time to see if they have relief of their symptoms. So the answer to all three of those questions are none, none, and none, right? Okay. So their conclusions: future research should focus on identifying more valid neuroimaging findings to diagnose intracranial hypotension accurately. That's the conclusion of the biggest study to date. Let's look at another study out of Japan. This is from Hosoya and colleagues, a consortium of 11 hospitals in Japan that collected 100 patients prospectively, not retrospectively. Let's look at what we found on imaging in the people who we diagnosed with leaks. Prospectively looking at the people we suspect might have a leak based on orthostatic headache. 89 had brain MRIs. Of those 89 brain MRIs, 20 are positive. 69 are negative. So what do you know? You know that, first of all, if you have an orthostatic headache, the likelihood that you're going to have any positive finding on brain MRI is quite low. The vast majority have brain MRIs that are read as normal, and I've already showed you a couple of examples of people who've had brain MRIs read as normal that weren't. What we don't know is how many of these 69 are false negative, okay? Is every single one of these patients, in fact, a leaker that just had a false negative MRI? Or is it 50%? Or is it 20%? I have no idea, and nobody else does either. 89 had radionuclide cisternograms. 70 had axial T2 spine MRIs, and 86 had MR myelograms. Of the 86 MR myelograms, exactly 3 were positive, all right? You know that at least 20 and maybe 89 actually have leaks, but at least 20. Only 3 have positive spine imaging on MR myelogram. 14 have positive imaging on the T2 spine MRI. They don't actually report the findings on the radionuclide cisternogram. I'm not sure why. When you add it all up, 16 people total had positive spine imaging. Are all of them the same as the 20? No. And we don't know, again, how many of the 84 are false negatives. When you combine them together, the positive spine readings account for 13 of the 20 brains. And so 7 of the positive brains show nothing on spine imaging, okay? So Peter Goadsby and colleagues went and looked at the experience retrospectively at UCSF. What they did is they searched the UCSF medical records for everyone who had a radionuclide cisternogram. They identified something like 80 patients, 79, something like that. And then they identified of those people who'd had a radionuclide cisternogram, how many of them had it, in fact, looking for a spinal fluid leak. And there was only 16 patients. And of those 16, 4 had negative imaging from everything: the radionuclide cisternogram, their brain MRI, their spine MRI. Everything was negative, so they excluded them. They looked just at the patients who had orthostatic headaches and positive brain imaging showing a leak, and who were drawn from this cohort of having had a radionuclide cisternogram. They identified 12 patients. All right? Of the 12 patients who had orthostatic head pain and positive brain MRIs, 8 had nothing seen on spine imaging, not on their radionuclide cisternogram, not on their CT myelogram, and not on the MRI. So among people with proven leaks, 3/4 were missed on every modality of spinal imaging. Again, making life harder for our Chiari surgeons, yes? Yes. Which is why I talk about maybe, in fact, it shouldn't just be that you get imaged. Maybe you should have to be flat before you get your cranium opened up for Chiari. Why does the rest of the world think that imaging is so much better? Because of studies like this. First of all, this is published by good authors, David Dodick, Dr. Starling. It's in the Annals of Neurology, a very good journal. It's not old, it's 2013. What did they do? They looked at spinal imaging a different way. Instead of saying, we're going to look prospectively at the people who present for a suspicion of CSF leak, we're going to look at the people who were definitively diagnosed as having a spinal fluid leak at Mayo over a 12-year period. And what they did is they identified 12 patients with orthostatic headache and a CT myelogram confirmed CSF leak. They wanted to know, is MRI as good as a CT myelogram for identifying this, so they could stop doing these myelograms. So they looked at the subset of patients who had orthostatic headache, a myelogram confirmed leak, and an MRI of the spine with and without contrast. And what did they find? They found that 11 of the 12 patients who had a positive CT myelogram also had a positive MRI. Okay. So what do they then say? They then say that spinal MRI has a sensitivity of 91.7%. All right? Sensitivity is supposed to be the percentage of people in their whole institution who really had a leak, who had it found on their MRI. We don't know what percentage of people came in and had negative imaging who really had a leak, right? It's totally absent. We have this word sensitivity should be nowhere in this paper. It's terrible. What they've really reported is an interclass correlation, a correlation between one imaging modality and another. And it's worse than that. All right, why? Because I'm guessing at Mayo Clinic, and I don't have the proof of this, but I'm guessing that if you show up and you have an orthostatic headache and you either have positive brain MRI findings or you don't, and they decide they're going to go look for a spinal fluid leak in your spine, what do they start with? Do they start with an invasive and radioactive test that injects a substance that can cause arachnoiditis? No, they don't. They start with an MRI. Okay, they get a spine MRI first. Who gets to get the CT myelogram? Does everyone get a CT myelogram, or do you only get the CT myelogram if, say, your MRI was positive, but it doesn't show where the leak is? That's when you get the myelogram, right? So what they did is they looked back at people who only got a myelogram if their MRI was positive in the first place. And surprise, surprise, when your MRI shows a leak, your CT myelogram, especially if you know there's a leak there from the MRI, is more likely to be read as positive too. All right. So this is an interesting thing. It does show some correlation between a leak large enough to be seen on MRI and whether you will in fact see it on CT myelogram. But in terms of making you in the audience, or the neuroradiologists who you work with, or the spine surgeons who you depend on, or the pain management people who you depend on to in fact patch, believing that in fact spinal imaging is 91% sensitive for finding CSF leaks is crazy, right? Especially when you consider that of the 186 patients that had positive radionuclide cisternograms, you know that very, very small percentage had evidence that would be considered in your hospital evidence of CSF leak. All right, so I don't know the sensitivity of these neuroimaging studies. To know the sensitivity, what I'd really need to do is get a group of people who had orthostatic headaches, again, assuming that you're less likely to find this in people who don't have orthostatic headaches. If you took a group of people with orthostatic headaches and you could take their dura out of their body, look at it all the way from neck to tailbone, turn it around, look at all the nerve roots, look at the front surface too, then you'd know what true positive is. You'd know what your gold standard is, and you could compare what percentage of people with imaging are positive and what percentage of the leaks that you could see with your own eyes are negative on imaging. But we can't do that. We have no good gold standard. I'll tell you what I think the gold standard should be, and nobody's done this. You know someone is leaking when you've created the leak. Those 40 people in the case control study, the people who have post-dural puncture headaches, those are your gold standard. They were fine, you made the leak, they became symptomatic, and in those people you never do imaging, you just patch them. It's a great irony. All right, here's someone who had spinal imaging that didn't show a leak. She was referred to me when I was still working in the pain clinic. I work in the headache clinic at Stanford now. She was referred to me to do some occipital nerve blocks on. I thought it was a little weird that she actually was referred for bilateral occipital neuralgia. I'm willing to believe that the occipital nerve can get pinched on one side or the other side, but I don't like the idea that it's getting pinched on both sides at the same time. And in talking to her, she told me that she had been totally fine until a particular day about a year before when her headaches started suddenly, and she was like 50 years old. Why does a 49-year-old suddenly get bilateral occipital neuralgia on both sides? Or for that matter, chronic migraine, which she might have been diagnosed with, or any other of the typical primary headache syndromes. And she told me that when she was at Disney World, she had a full-on grand mal seizure at the age of 50 without any clear inciting event. And that constellation made me think we should look a little harder for a leak. And at that point, I hadn't read Schevenk's article that identified, we talked about yesterday, looking at precipitating factors among people who can identify a precipitating factor in CSF leaks. Remember that one of them identified roller coaster? Like, I didn't know about that then, but now when I think about her having a grand mal seizure, where? At Disneyland, right? What was she doing? She was riding the roller coasters, or some other such thing. She's got this teeny little disc. It looks like absolutely nothing on that sagittal MRI. This is what it looks like on her axial MRI. This was not even commented on in the report. On a CT myelogram, this is what it looks like. Nice little calcium spike penetrating right through the dura all the way to the cord. And this is all that you see that indicates there's any spinal fluid escaping there. That, and this is the level above. This little nerve root contrast. And you know what the radiologists say when you look at that with them? They say, well, we see that sometimes. Oh, you see that sometimes, but you just happen to see it above that and below that. Now, when you do a blood patch, we showed this yesterday, often you just get the blood on the back surface of the thecal sac. Here's the spinal cord, here's the bag of fluid. If you've got a calcium spike coming through the front, your typical blood patch isn't going to do you much good. So what we did is we did a transforaminal approach, coming in like this, next to the rib, tried to put the tip of our needle about here. We still get a lot of spread over here. You can see the glue here spreading around. The thecal sac is now here. The glue spreads around. It does, in fact, cover the base of the osteophyte. And when we did this, she had complete relief of her symptoms for 2 or 3 weeks, but then it came back. The nice thing, again, when you inject the glue, because you don't want to compress the cord here, you're injecting like 2 cc's of glue. If you inject 2 cc's of glue here and they get better, you know the leak is there because it doesn't spread up and down. So now we know she's leaking, it really is a leak, and that's where it is. So we could send her to the surgeon. Here's another one with a bone spur. You can see they've had a fusion. This is C2, 3, 4, 5, 6. They've had a 6-7 fusion. At 5-6, they have a transition zone where the disc is degenerated above the fusion. And the disc that has degenerated has calcified, and you've got this little bone spur here, blown up, magnified there. You can see on the axial, it looks like it's got a little pointy dynamic to it. And in fact, what do you see right next to that bone spur that you saw in that last myelogram? Just a little bit of contrast along the nerve root. But you know what? We just see this sometimes. Here's somebody who, in fact, had a failed Chiari surgery, and she had her posterior fossa opened up. She was diagnosed with Chiari, was also diagnosed with POTS, all right? If you're diagnosed with Chiari and POTS, it's terrible, right? Here's the little bone spur that was causing her leak, and again, just a little bit of contrast out here, which we see sometimes. All right, other little fractures, pars fractures. Turns out a lot of young men who play football get these little pars fractures. This caused somebody to get full-on imaging positive on brain MRI, CSF leak with subdurals and everything. You can see, just a little pars fracture, a little bone pushing into the thecal sac. This is the one you saw yesterday. This is also one you saw yesterday, and I put it in here just because you weren't here yesterday, and I wanted you to see. That's all right. I wanted you to see one of these CSF venous fistulas, all right, which you'll miss. You will not see this at all on MRI or conventional CT myelogram. Interestingly, you will get an indication that this is going on if you do a radionuclide cisternogram, because the radioactive tracer leaks out here, it gets into the venous system and quickly winds up in the bladder, and early bladder filling is one of the positive findings you'll see on a radionuclide cisternogram. We talked about these new imaging findings, mammalopontine distance that in fact indicate a CSF leak, usually not commented on by the radiologist. This is the mesencephalic pontine angle. These authors have reported that if this is under 50 degrees, that enhances the likelihood that you really have a CSF leak. Again, not getting reported pretty much anywhere I know of. The symptoms of a CSF leak, we talked a little bit yesterday. It's not just a headache. These people are miserable and incapacitated because of symptoms that they have that go beyond headache. Neck pain, feeling fatigue, chronic nausea. We've seen women lose 60 pounds in a year from vomiting 6 to 8 times a day. The ringing in the ears, the neurologic confusion. And this is somebody who did that 48-hour flat test. Most of you were introduced to this yesterday. We ask people to basically, when they go to bed on Friday night, before they go to bed, to rate their symptoms of head pain, neck pain, nausea, difficulty with thinking, concentration and memory, tinnitus, and fatigue, the core symptoms of a leak. And then when they wake up on Saturday morning, instead of waking up and starting their day, they go to the bathroom, they get back to being flat in bed. Stay in bed all day Saturday. Do the same thing Sunday night. Wake up Sunday morning, stay flat in bed. Then when you get up at about 5 p.m. on Sunday, you rate those symptoms again. Before you get up, before 48 hours flat, after 48 hours flat. And then, just for good measure, we have them rated again 2 hours after getting upright. Can you use opening pressure to tell you whether, in fact, someone is leaking? This is out of the group at Duke, a great study from Peter Krantz, where they looked at people who had positive myelograms and negative myelograms and looked at their opening pressure. And you know what they found? Their opening pressure's no difference at all between people with a leak and people without a leak, and in both groups, the average pressure was above 8. You've been told that if someone has a leak, they're going to have an opening pressure of less than 6, that you can use an opening pressure of less than 6 to rule in or rule out a leak. In fact, all of the people who had a leak present, their average pressure was above 8. Another study of people who had confirmed leaks based on imaging found that 1/3 of them had normal opening pressures. We have noted, and it has been reported, that when you have some brain sag, it can put traction on the pituitary stalk, and you get hypothalamic pituitary dissociation. And the first and most obvious sign of that is an elevated prolactin. We ask all the patients who come into the headache clinic now about galactorrhea, and everybody who has orthostatic headaches gets a prolactin. We only find an elevated prolactin, maybe 1 in 5 of them, but it gives you a hint that you're on the right path. When we do our myelograms, we get CSF glucose, protein, and cell count on all of them. About 40% of people with leaks will actually have elevated protein. In one case, series 7 of 12 had elevated CSF protein. Another found average CSF protein was 56 in a group of patients with CSF leak. Shouldn't be higher than 45. So our working hypothesis at Stanford is the specificity of the existing imaging modalities that we have is high. The sensitivity is low. And if that's the case, we would argue that it should be treated as a clinical diagnosis, not a radiologic diagnosis. All right, so we should be looking as a clinical diagnosis at people who are at high risk. They either have a hereditary disorder of connective tissue, they've been instrumented, or they've had major trauma. We look at all their symptoms, as we've talked about, the imaging, the CSF protein, and then what we do to kind of resolve what we're going to do in an ambiguous situation, which is what you usually wind up with. Maybe the CSF protein's high, the imaging is read as normal, they've got a good but not perfect story for a leak. Should I be sticking a needle into their thoracic spine next to their cord and injecting glue? I don't want to be out there making that decision all by myself and second-guessed by my colleagues the next day. I want the second guessing to happen the day before. And so what we've done at Stanford to kind of make sure that these cases are appropriately vetted so that somebody's not saying, Dr. Carroll lost his way. He's just gone leak crazy. He's leak crazy. We have essentially a tumor board type group conference that meets every 2 weeks where we go over these cases. Neuroradiology's there. We have neurology headaches faculty there. We have me there. And we go over the cases and we vote. And if I'm the only person who thinks you should get a patch, you do not get one. There have to be other Stanford experts in headache and neuroradiology in the room who say this should be patched. That gets into the medical record, and then you get an offer to patch or you don't. And it's a nice way of breaking through that in that kind of ambiguous thing, that ambiguous situation, to offer someone what you think is appropriate treatment, but you can't prove is appropriate treatment. And frankly, we're straightforward with the patients. We're not sure you have a leak, but we think it's worth trying this. And in that setting, I have not had one patient be like, no, if you're not sure, I'll pass. All right? Other people have noted that in the face of ambiguity, you should do this. So this is from the ICD-3 section on spontaneous intracranial hypotension. And I'll read it because I think it's important. And I think in many parts of this country, if your imaging is negative, you're stuck. And the consensus among the experts who came up with these ICD-3 guidelines said, basically, in patients with typical orthostatic headache and no apparent cause, and after exclusion of POTS, it's reasonable in clinical practice to provide an autologous lumbar epidural blood patch. These are the experts saying in their collective wisdom, if you don't have POTS and you have an orthostatic headache and your imaging is negative, you should get offered a patch. And so people should know about this so that they can cite it in their medical reports or when talking to patients or in trying to convince a colleague to help. You're not going to be out there on your own. This is what the experts recommend. I would argue, in fact, that we don't have good proof that tachycardia can differentiate between a symptom of autonomic dysfunction and CSF leaks. Jürgen Beck in Germany has published a case series of 9 patients with imaging-confirmed CSF leaks where he measured the change in their heart rate between being flat and being upright. All 9 cases would have met criteria for POTS. So I don't think we should be, I would actually argue we should be taking this thing out, this caveat, that even if you have POTS, maybe it's reasonable if you have headache as part of your orthostatic syndrome to be offered a patch. Complete relief of symptoms may not be achieved until 2 or more have been done of the patches, all right? You've got it right there in black and white coming from the experts saying you should try this. All right. And I am no longer able to advance. There you go.
If they have no response after the first one, 0 response, do you go to a second one?
It depends. So, and I'll tell you what it depends on. It depends on how good their story is. It depends on how many places look suspicious on their myelogram. Sometimes they've got a bone spur here, and they've got a bone spur there, and they've got a big perineural cyst here, and you don't know where they're leaking. And you pick the best spots, and you try and patch there. If they have a really compelling story, we'll often give them more than one patch. In our, looking back at the cases we've seen, well, I would say 2 things. First of all, in spontaneous leaks, the reported efficacy of the first blood patch is 30%. With repeated patches, the published numbers are you can expect to get up to 65 to 75%. With how many patches that take being a poorly defined thing in the literature yet. I'm going to wait to the end to take questions. If you do this, if you practice this way, this is what you will experience. This girl, whose MRI was read as negative, and who had this on her CT myelogram, now looks like this. She was on disability before. This guy, who was incapacitated, and he had this bizarre story. He thought his symptoms, which were largely brain fog, in addition to headache, were because he had had carbon monoxide poisoning on some work site. I was ready to just blow him off, thinking he was crazy, but he did have this. His MRI was read as negative, and that's what he looks like after being patched. And the reason I didn't blow him off is because I'm 6'2". Look at that guy. It wasn't until he stood up at the end of the interview that I was like, all right, you're getting a CT myelogram. All right? He went back to work as a gameskeeper in South Africa with his lions. This is the woman who had the Chiari and still had symptoms after her Chiari decompression. You can see the evidence of the Chiari decompression there. And this is what she looked like after getting patched at that bone spur. She had her leak come back and had to go to Cedars to have surgery on it. Her MRI was read as negative, and that was her after getting surgery. I will tell you that her leak recurred, and she was offered a salvage surgery, but quoted some percent likelihood of being paralyzed. And she declined, and so what we did is we started doing fibrin glue patches at that osteophyte again. And every time we do it, she'd get totally better for a few weeks, and then her symptoms would come back. But they wouldn't come back quite as bad as they were before. And so after about 8 or 9 thoracic transforaminal patches at that osteophyte, she is now back to this. Happy and symptom-free most of the time. Every so often she'll get some leak symptoms, and they're much more mild and they go away. This is the one that had the dural puncture that was out there for 18 months before we figured it out. Another MRI that was normal, and what she looked like after getting patched. Imagine if we'd have stopped because all those people had normal MRIs. And that was my daughter when she was leaking, and that's her now. We've seen the leaks diagnosed and misdiagnosed as chronic migraine, chronic daily headache, new daily persistent headache, Chiari, POTS. We've seen it misdiagnosed as chronic fatigue. We've seen it misdiagnosed as traumatic brain injury. I had this trauma, I hit my head, now I've got headache and dizziness, and I don't think the same way I used to. My MRI is negative. Oh, maybe that's a traumatic brain injury, or maybe that's post-concussive syndrome. Except POTS, none of those should get better with prolonged flatness. If you really have a brain injury, being flat for a weekend shouldn't make things any better. If you really have post-concussive syndrome, being flat shouldn't make things any better. So what are we doing? For me, having lived through that with my daughter, one of the things I want to do is I want to make sure at least all the people at Stanford who have a leak are in fact treated. I've done the first step, which is gone out to the Marfan clinic and said, hey, you get people at Marfan clinic who have a headache, come see me. I've gone to the POTS clinic and said, hey, people with POTS, big headache, let's evaluate them. But I want to do better than that, and so I want to tell you what we're doing at Stanford. What I want to do is I want to use the EMR to find these people. I want to find people in the EMR who have headache, neck pain, dizziness, vomiting, bring them in and look at them, right? But I want to do it even better than that, because I know that in fact if you have a spontaneous leak, that your imaging may be negative, and I know that if I patch them, I'm going to have to patch someone with a spontaneous leak a bunch of times because I don't know where their leak is, and the patching in the spontaneous leaks is less effective. It takes more patches. And so we're going to start with the easiest group. We're going to look at people who have been in the medical record at Stanford for at least a year and have no symptoms of a leak. No headache, no tinnitus, no nausea, no tachycardia, nothing like that. Then they have a known LP at Stanford, a known lumbar puncture. And we're going to look for people who in the next year, like Pam Flood's patients, have the new development of those CSF leak symptoms, all right? Where the symptoms that we're looking at are headache, migraine, nausea, tachycardia, dizziness, vomiting, tinnitus, fatigue. And so the question is, how many people at Stanford fit this profile. And that data, these are the symptoms we're looking at. That data set looks like this. And when you make a histogram of that, what you have is, of the people who had a lumbar puncture, we looked at 4,000 lumbar punctures, which is not the whole ball of wax. That's just in a data set we have access to right now. If you look at 4,000 patients who had lumbar punctures, who fit that profile, who have no signs of a leak at all for at least a year before their LP, and then develop those symptoms afterwards, this is how many patients have no symptoms. Lots. Lots of people are just fine. This is the number of people who have 2 symptoms. And these are the people who have 5 or more symptoms of a CSF leak. They have 5 or more of these symptoms that they did not have before having an LP at our institution. And I want you to see that this is 0 to 100. There's 100 patients out of that 4,000 here who had none of those symptoms, had a known LP, now have all of those symptoms. So we want to bring them in where we think we know where their leak is and patch them and see how many get better. And then if we see that lots of them get better, we'll share that little algorithm for the EMR with Kaiser and with Harvard and Johns Hopkins, and hopefully bring more and more people. These people are coming into Stanford looking for help with these symptoms. They're not getting diagnosed. All right, that's all I've got to say. Thank you very much.